Okay, so good afternoon, and thank you so much to the organizing group for the opportunity to be able to speak with you today. It's a real honor for me and a privilege to be able to address the group. As stated, I'm going to talk about COVID-19 transmission. I'll echo some of the themes developed by Professor Cowling, and then focus in particular on risk to healthcare workers. These are my disclosures, and here we go. It's remarkable to think that it's barely a year ago that we learned about the outbreak of severe pneumonia cases associated with the wet seafood market in the city of Wuhan. As we know, the virus thereafter rapidly spread across Hunan province in China and then beyond. Here it is in Italy. Here it is in South Korea. This is Iran, Thailand, the United States, and of course it's in Hong Kong as well. It's now, in terms of case counts, we're up to over 68 million cases and 1.5 million deaths. And this is a massive underestimate. The World Health Organization estimates that at least 10% of the world population has already been infected. So that would be over 700 million people, meaning that we're undercounting cases by a factor of 10. What's also shown inside this map over here is the countries with the number of case counts per 100,000 people over the past week. In other words, the countries where there's a great deal of disease occurring right now. You can see that as of right now, the real hotspots are the United States and much of Eastern Europe. In terms of new cases per day, here the case counts corrected for size of population for the United States versus Europe versus South America versus Asia. You can see that things are by far and away the greatest amount per population size in the US. But let's shift gears and talk about transmission. So I'd like to review some of the basic aspects of transmission, the mechanisms of transmission, aerosol generating procedures, and then talk about healthcare worker infections. The incubation period, the time period from when a person first gets the virus until they first manifest illness, is on average around 6 days. However, you can see there's a wide variation over here, going from anywhere between 2 days up to around 14 days, and occasionally even beyond. The question has arisen, how long are people contagious for before they develop symptomatology? We're all very aware of the cases of people who interacted inside some group, were perfectly fine at the time, developed symptoms a day or two later, and lo and behold, they'd infected a large number of people in that group. I want to share with you some of the science behind this because I think it's remarkable and quite fascinating. So the way that the quantification of the period of infection prior to development of symptoms is done as follows. What you do is identify individuals in which you know that a pair of individuals where person A gave it to person B. For the person A, you know they had an incubation period, and then you know they had symptoms. Then you find the second person to whom you know they gave the infection, and you know, of course, when that person's symptoms began. The gap between the two symptom onsets is called a serial interval. Once you know when the second person's symptoms began, you can back project upon that the usual incubation period. And this period of overlap over here between incubation periods is a period of time during which pre-symptomatic transmission was taking place. Now, if you do this exercise for a few hundred pairs of patients where you know A gave it to B, and you map these intervals, you can come up with a curve that looks like this, that tells you that the period of greatest infectivity is about 2 to 3 days before symptom onset, and thereafter rapidly declines after about a week. In a person with mild illness, they are no longer contagious. Let's speak about the big controversy, though, as to how the virus passes from person to person. And the controversy in particular is, does it spread by droplets or by aerosols? So here's a remarkable photograph taken by a researcher at the Massachusetts Institute of Technology, where she's been able to capture the different kinds of respiratory particles that a person emits as they breathe, speak, cough, or talk. And you can see shown in here in green are the larger respiratory particles. These are the droplets, which are large enough that they can be carried to the ground by force of gravity within a short diameter around the person, typically a range of around 1 to 2 meters. Also shown in red over here, however, are the aerosols. These are much smaller respiratory particles that are small enough and light enough that they can remain suspended in the air, be carried by air currents through outer space, and lead to much longer range transmission. Now, the truth is that it's a biological system and that people produce both on a continuum. There's no hard cut and fast distinguishing line between droplets versus aerosols. So if you look at the respiratory emissions that a person puts out, you'll find that they put out respiratory particles of a range of sizes. Look at the blue line over here. This is the count of respiratory particles as a function of the size of the particles down below. In the left-hand side of the graph over here, these would be the aerosols, the much smaller particles, the ones that can remain suspended in the air for long periods. On the right-hand side would be the droplets, the bigger respiratory particles that fall to ground rapidly. And what you can see is that it's a continuum. People are putting out respiratory particles of all sizes at all the times. What this figure also shows is that the amount of particles that a person puts out varies by exactly what they're doing. So simply breathing emits these respiratory particles, speaking emits more, and the loudness of your voice leads to the generation of even more. So a loud person is putting out this many particles. A person speaking with an intermediate or quiet voice is putting out far fewer particles. The other thing that varies over here is the amount of particles varies by person. So if you take a group of people and you have them all do the same exercise, in this case, reading an English passage at about the same tone of voice, what you'll find is that most people put out this many particles, a relatively small number, but there'll be some people who put out far more particles compared to others. And these will be the so-called super emitters. Now, you can start to get a glimpse of some of the factors that might lead to more transmission. If you have a person who's very early in their stage of infection, in their pre-symptomatic or immediate symptomatic period, and they're speaking loudly or singing or coughing, they'll put out more. If they happen to be a person who biologically is a super emitter, they'll put out more. You combine those factors together, and you can see that some of the factors that might lead to more transmission compared to other circumstances. Now, a question associated with this is how far do these particles travel? And the answer is it varies widely depending on the person. This is looking at these figures, looking at over here, the distance that a cough wavefront will carry in a different person. This is looking at 5 different subjects, and you can see the distance varies by person, anywhere from 1 meter up to 2.5 meters. So beyond sort of the classic 1 meter or 2 meter that we usually cite as the distance of travel of respiratory emissions. You can see parenthetically over here that a mask makes a big difference. A mask will cut that distance by half or more. So instead of 1 meter to 2.5 meters travel distance, you'll see with a mask, it goes down to around 20 centimeters up to 1 meter. Now, so there's a lot of variation by person, and it is possible for those respiratory particles to get beyond 1 or 2 meters, although that appears to be the exception rather than the rule. If you're dealing with aerosols, of course, they can travel beyond the distance of the cough wavefront because they can remain suspended in the air. So then what then is a protection for a person who's at a greater distance? Why don't we commonly see more distant transmission taking place? So look at this picture, which I hope will give you some sense of the reason why. This is a simulated picture of a person who's coughing and using a laser methodology to be able to visualize for us these respiratory particles, in particular the aerosol component. Look at the respiratory plume over here at 3 feet. Here it is at 6 feet. And here it is at 9 feet and 12 feet. And what you can see is that the further away you get from a person, the more dilute the respiratory cloud will be. It gets diluted, it gets diffused, so it spreads out, so that the net amount of virus at distance becomes less and less. So you look at compare again the difference between the density of respiratory particles at 3 feet compared to out here at 12 feet. What that means that in practice, the further away you get from a person, even if there's aerosol-based component to their transmission, which there is, you will see that you're exposed to less and less potentially respiratory emission, and that then becomes your protection. Now, the key role over here of distance and time as factors in transmission is borne out beautifully in this amazing study from China, where they looked at high-speed travelers and were able to calculate the risk of infection as a function of both distance and time. What they did is they identified over 70,000 people who rode on high-speed trains, and they were able to link exactly where a person sat on the train with their medical records as to who actually acquired COVID-19. So if you imagine for yourself the index patient sitting in a seat, if you happen to have the misfortune to be seated right next to that person, you had a 3.5% chance of catching COVID. If you were 2 seats away, 1.7%, so literally half. Now, 2 seats away is about 1 meter. If you were 3 seats away, your risk of transmission went down to 0.4%. That again is only 1.5 meters away. So you can see the dramatic impact of even small increases in distance leading to a large decrease in the amount of transmission taking place. If you were in the row in front or the row behind, even smaller amounts of transmission taking place. Again, probably because of the seat itself acting as a barrier to transmission for the people in front, and the lower probability of respiratory emissions moving backwards behind the person for people sitting in the row behind. Now, because these were train trips, you could take into account not only the distance from the index patient, but also the amount of time that you spent in proximity to that individual. So this over here is showing the function of the duration of the train trip in hours with your risk of getting infected. So you can see for a very brief journey over here of less than an hour, the risk of infection around 0.2%. For a much longer trip coming up here to about 8 hours, the risk of infection going up almost tenfold to almost 2%. So again, the key factors in transmission over here are proximity and duration. Now, we spoke about the capacity of distance to lead to dilution of the amount of virus to which you'll be exposed as a function of diffusion and dilution. There is one major exception to that, and that's a situation where there's very poor ventilation. The problem with poor ventilation is it allows for accumulation of those respiratory emissions to the point that they can no longer be diluted, but they're just going to accumulate within a common space because there is no air turnover. And that helps to explain some of the very large clusters that have famously been reported. Pictured over here is the Skagit Valley Choir, which was a senior citizens choir in Washington State in the United States. And the story of this group was as follows, was that back in March, 61 members of the choir attended practice together on March the 10th, and no fewer than 53 of them developed COVID-19, an 87% attack rate. 3 of them were hospitalized, and tragically, 2 of them died. Now, the investigation went as follows. It turned out that one member of the choir had flu-like symptoms 3 days before practice. It was later found to be positive for COVID. Now, it was a 2.5-hour practice session. There was no masking. The participants were quite close to another. It was about 6 to 10 inches apart. However, you can see by that high attack rate, this really affected everybody inside the room. It wasn't simply clustered around the sick individual. Now, the key thing was that they went ahead and they tried to measure the amount of ventilation, to quantify the ventilation in the space on the rationale, again, that with poor ventilation, it allows for accumulation of those respiratory particles and therefore of the virus. The air change rate inside this choir practice room was estimated to be 0.7 air changes per hour. Now, to give you some context for that, in a clinical space, at least in the United States, our requirement is that air changes have to be 6 changes per hour or more. So in other words, a full 10-fold greater than the amount of air change that was taking place inside this choir practice area. Let me tell you about another cluster that further sheds light on the potential role of aerosol-based transmission in a poorly ventilated space, but also the limitations, the notion of even with a little bit of increased ventilation, how you can substantially diminish transmission. This was also another very well-reported cluster. This took place in a restaurant inside of China. The story over here was that person A1 had just traveled from Wuhan back to the home city, went out for a celebratory dinner, and took a number of family members out to eat. And you can see that no fewer than 4 people at this person's table became infected with COVID, as well as 3 people on the table to one side and 2 people to the table on the other side. Now, the particularity in this story was that there was an air conditioner on one wall. It was blowing air from right to left, so in this direction. And there was an exhaust fan on the opposite wall, but it was closed. So what happened in practice was the air was set up a circulation loop, going from right to left, across the tables, and then bouncing off the wall and coming back again. That meant that the distance the virus was traveling from A1 to get all the way out to people in C2 was around 12 feet, around 4 meters. So quite a lot more than the 1 to 2 meter classic distance that public health sometimes quotes. Now, they went ahead and did some modeling of the airflow in the space using a tracer gas. And so here is our air conditioner. You can see the 3 tables at the back. What you also see as well in this picture of the restaurant was in fact that there were many more tables inside this space compared to what you saw on the prior slide. So at the back of the restaurant where you had the circulation loop, where basically the amount of air was just going in a loop, there was very little dilution of that air. Think of it therefore as a very poorly ventilated space. The attack rate was 45%. But there were another 68 people inside that same room, ostensibly exposed to that same air, but outside of that air conditioner circulation loop, and none of them got infected. Meaning that just a little bit of dilution of that air from the back of the restaurant was sufficient to protect the other people in the restaurant. Likewise, none of the 8 waiters in the restaurant who were going to the back to those 3 tables where there was poor ventilation, none of them got infected. And that probably speaks to the smaller amount of time that the waiters spent in that area of the restaurant. So the protection, again, was a little bit of dilution of the air by being away from the back section of the restaurant, or a short duration of exposure, as in the case of the waiters. Now, interestingly, when they went ahead and quantified the air changes at the back of the restaurant in the circulation loop, they came up again with the exact same number as in the prior cluster, 0.7 air changes per hour. And again, that's about 1/10 of what we enjoy inside of our clinical spaces. The take-home message over here is that aerosol-based transmission is very much a reality. Certainly short-range transmission takes place, and that long-range transmission can take place under conditions of poor ventilation. But it's to the extent that you're able to improve that ventilation, it substantially diminishes the long-range transmission from aerosols. Let me tell you about a third cluster, which brings out the role and benefit of outdoor air compared to indoor air. So this was a cluster of 31 infections associated with 300 people who attended an outdoor Buddhist ceremony in Eastern China. And this was traced to one pre-symptomatic attendee. Now, the story was this ceremony took place outside of town, and therefore people had to get there. And they got there by 3 different ways. There were 2 buses, or people took private transportation. They went in their own cars. The people who went onto bus 1, which happened to be carrying the pre-symptomatic individual, 35% of them became infected. The people who went on bus number 2, 0% of them became infected, despite the fact that the actual ceremony itself was, of course, intended by people from both buses, suggesting that the transmission really took place on the bus itself, where you have poor air circulation, so you're simply recirculating the air continually. But for the outdoor component, there was very little transmission taking place. For those who drove in private cars, it turned out that 4% of them became infected. But the story was for each of those individuals who became infected, who took private transportation, they noted they had close contact with the index patient at the ceremony. Notice that they had the problem of proximity. So what you can see over here is that outdoor air substantially diminishes transmission, but it's not perfect protection against very proximal, face-to-face close contact with an infected individual. Let's start talking now a little bit more about healthcare worker-associated infections. And I want to answer this grand mystery, which I think has been bothering me for months and months, which is, what is an aerosol-generating procedure? Now, there's this very well-cited review put out by the World Health Organization looking at different kinds of medical procedures and looking at the association with transmission of SARS-CoV-1. There's the SARS that you know very well from 2003. And what they found in case control studies was there was a very strong association with tracheal intubation and an increased risk of healthcare worker infections, a 6-fold increase in SARS-CoV-1 infections among people involved in tracheal intubation. Then, looking at similar sorts of studies, looking at other kinds of procedures, this review also noted an association with non-invasive mechanical ventilation, manual ventilation before intubation, tracheotomy, and cardiac resuscitation with a greater risk of healthcare worker infections. However, if you go ahead and you actually try to measure aerosol generation associated with these procedures, you'll find something quite striking, which is that a lot of these procedures, including intubation, bronchoscopy, etc., actually generates very few aerosols. So here's a study looking at aerosol quantification during controlled intubation in an asymptomatic patient. And you can see over here with intubation over here, very few aerosols generated. Extubation, tiny amount of aerosols generated. Asking the patient simply to cough on a voluntary basis, a large amount of aerosols. So here's a real paradox. The so-called aerosol generating procedures generates very few aerosols. Coughing, which is an ordinary symptom of the disease itself, generates a large amount of aerosols. So it seems like things are upside down over here. How do we account, therefore, for the greater risk of infection associated with intubation? Now, this issue of very small amounts of aerosol generation is not limited to intubation alone. Other investigators have looked at other kinds of studies and likewise have documented with mechanical ventilation, with extubation, with bronchoscopy, with suctioning a patient, very small amounts of aerosol generation. The only exception over here was nebulized medications. And of course, that's because nebulizing a medication is designed to create aerosols. So you expect there to be aerosols, but it's aerosols of the medication, not necessarily the patient's emissions. So how then do we explain the intubation paradox? And what I would like to suggest is that it's not the procedure, it's the patient. The kind of patient on whom you have to do an emergency intubation or mechanical ventilation or bag valve ventilation or cardiac resuscitation are the kinds of patients who are very sick, they have serious illness, they're highly symptomatic, they require the healthcare worker to be very close to the respiratory tract and possibly for a sustained period. In other words, you have the coming together over here of serious illness, symptomatology, profound proximity, and sustained exposure, which we know are the risk factors for transmission. So it's not the procedure, it's the circumstances surrounding the procedure that lead to the increased risk of infection associated with so-called aerosol-generating procedures. Now, taking this all together, how contagious actually is COVID? And we have good data on that now from contact tracing studies from around the world. And I'm going to share with you a couple that give some flavor for this. So this was a contact tracing study from Ningbo City in China. They identified about 2,147 close contacts of 147 cases. And of those, 6.2% became infected. Now, it's worth pausing for a moment, because I think you'll be forgiven if you thought like I did back in February and March, as we watched the relentless march of COVID across China, then across Europe, and thinking to ourselves, wow, this is an incredibly contagious virus. But it turns out that only about 6.2% of about 5% or so of close contacts end up getting infected. Now, even amongst close contacts, 19 out of 20 people do not get infected. Now, even within that 5 or 6%, it varies by the nature of your interaction. The greatest risk is for a household member. You can see over here, the secondary attack rates for household members was 18% in the study. Other studies have found even higher rates than that. And you can think about it, you know why? Because a household member shares both proximity, right? There's intimacy, there's closeness, there's hugging, there's sharing meals together, and there's duration, long periods of time spent together. And in addition to that, there might also be poor ventilation. So that's why households are such high transmission zones for COVID. The next greatest risk is eating together. And that also makes sense because, of course, if you're eating together with somebody, you're likely going to be face to face with them for a long period of time without a mask, talking, laughing, singing, discussing, and therefore sharing respiratory emissions with one another. Relative interaction with relatives around 5%, simply going shopping, much less than 1%. Here's another contact tracing study showing similar findings. This one here is also from China. This was 3,410 close contacts of 391 COVID patients. Close contacts over here were identified both by interview and by cell phone tracing, so more complete case ascertainment likely. And of the close contacts, in this case, 3.7% became infected. So just like the prior study, the transmission rate to close contacts around 4 to 5, 6%. And as before, the attack rate varied by setting, with household members being at greatest risk, 10% in the study. Entertainment venues or workplaces, 1.3%. Healthcare settings, only 1%. And remarkably, public transport, only 0.1%. The other factor that affects transmission is severity of illness. The more severe the illness, the higher secondary attack rate that there is. This is from the same contact tracing study we saw a few moments ago, except over here, they quantified the amount of secondary transmission as a function of severity of illness. Now, amongst asymptomatic contacts, the rate of transmission you can see over here was extremely small, substantially less than 1%. But the moment you have even mild symptomatology, that attack rate goes up substantially over here to the point where you have moderate or severe symptomatology, you're tenfold or more higher, more likely to transmit compared to an asymptomatic individual. One of the offshoots of this is why it is so important to message to people that if you have even mild symptoms, a bit of a runny nose, sore throat, not much, the sorts of things that historically speaking we tend to ignore, that we historically speaking always used to work through, you cannot do that with COVID-19, because if you have any kind of symptomatology at all, what this slide tells us that A, you are more likely to actually have COVID, and B, you are more likely to be contagious. And that's why there's strong messaging now that people cannot go to work, cannot go to school, cannot work in the hospital, even with mild symptomatology. Where does COVID fall out compared to other kinds of respiratory pathogens? So we heard from Dr. Cowling about the R0 number, the so-called reproductive number, the number that estimates on average how many people are infected by each person with the disease. You can see the R0 for COVID comes out anywhere between 3 to 5, depending on which study you're reading. Of course, it varies by the nature of the circumstance in society at the time that you measure it. And by comparison's sake, that's more than flu and more than SARS-1, but substantially less compared to varicella, pertussis, and measles. Now, all these diseases are all spread by respiratory emissions and therefore by a combination of aerosols and droplets. What then accounts for the difference? It probably has to do with the infectious threshold, the amount of virus that's likely to cause infection in a recipient. And I think what you can impute from this is it takes much, much less measles virus to cause an infection compared to the amount of COVID that's likely to cause an infection in another person. It's all about probability, of course, but this on average appears to be the pattern. Now, the fact that COVID is more contagious than flu has really been brought home to us by the influenza surveillance that's taken place over the past year. What you see over here is World Health Organization counts the number of influenza cases from the Southern Hemisphere. You can see the traditional influenza season from prior years with large numbers of cases, the traditional fall during the summer, last year's increase during the winter, then with the arrival of COVID, the almost a complete elimination of flu as COVID then took its place. Now, it's unclear why this took place. And I think there are two going theories. One is that maybe COVID and influenza are competitors, and that COVID is simply a much, much better competitor and therefore so eliminates influenza. I actually don't think that's the case because you can see case of co-infection of flu and COVID. It's not that uncommon. Another potential explanation, again, this is simply speculation, is that the kinds of social distancing and masking measures that people undertook in order to decrease COVID were okay for COVID, but very effective against flu. In other words, they kind of did the job with COVID, but for flu, they almost completely eliminated it. Here's data from Australia that further echoes that theme and actually looks at the other kinds of impact on other kinds of respiratory viruses. So this is the count of pathogens per week in a respiratory testing center where they did broad range PCR on all respiratory specimens looking for a range of different respiratory pathogens. Shown in blue is rhinovirus, in red is COVID, and in orange is influenza. What you see with as they went into lockdown over there was a dramatic decrease in all respiratory viruses, but whereas they were able to bring flu and COVID down to near zero, the moment they started to lift their lockdown, rhinovirus came springing back. And of course, this echoes the data that Dr. Cowling was showing that in his mask-based study, that while masks appear to be quite effective at blocking influenza and common coronavirus, it seemed to have much less impact on rhinovirus. And perhaps that's a factor that fits together. So if you put this together over here, what are the kinds of circumstances in which people are getting infected outside the home? This comes from a case control study of people with symptoms who presented to COVID testing sites in the United States. And what they did is after they tested people, they are divided into people who are COVID positive and those who are COVID negative. And they asked them, what have you been up to the past 2 weeks? Tell us about the kind of activities you've been involved in. And what you can see over here, that those who are COVID positive were much more likely to report going to a restaurant or spending time in a bar or a coffee shop. Again, echoing back to our comments before about how shared eating or drinking together is a real risk factor for transmission because you're face to face without a mask for a sustained period, often talking at the same time. How long are people contagious for? So we have good contact tracing studies again, which lend insight into that. Here's a study of 2,500 close contacts with about 100 patients with COVID in Taiwan. And for people who had contact before the person developed symptoms, an attack rate around 1%. That was consistent for people who had contacts up to around day 5 of symptoms. But thereafter, from day 6 and beyond, the secondary attack rate dropped down to 0%. Again, suggesting what we saw before, which is for mild illness, the duration of infectivity is about a week after symptoms begin. That's also echoed out by viral viability studies where we actually try to culture virus. So these were all individuals who had positive PCRs, but they went ahead and took those specimens and tried to culture them to see if they actually had replication competent live virus that could potentially infect another person. You can see by day 7 after symptom onset, about 40% of people had live virus still present. They continued to drop off by day 10. Beyond day 10, dropped down to 2% or less. And that informed the guidance inside the United States and the World Health Organization of 10 days as a standard period for isolation for somebody who has COVID, counting from the time of symptom onset. You can also look at the cycle threshold as a way to quantify the amount of virus to also get some flavor of likely infectivity. And as you get to cycle thresholds above around 32 to 35, the likelihood of having replication competent virus drops off substantially. Another question I think that's coming up for us a lot inside the United States, as we have so many cases, is how reliable is a post-exposure test to rule out COVID transmission? So here's a very nice study looking inside of a household. Now remember, again, that households are a very high risk proposition. But what they did in this study run by the US CDC was identified 191 household contacts of 101 patients with COVID, and they tested them every single day. And that's critical because such a high fraction of people with COVID have asymptomatic or pre-symptomatic status. And therefore, if you're waiting to look to detect symptoms alone, you're going to miss a large chunk of people who actually are contagious or actually have acquired the infection. So the message in this study was that 53% of household contacts ultimately tested positive using the strategy of testing every day, so multiple testing, and testing everybody, including those with no symptoms. That secondary attack rate was consistent, even if for very young index patients, if the index patient was less than 12, and similar sorts of numbers if the patient was if the index patient was a teenager. Here's the key point, that by day 5, you only picked up 75% of the household members who ultimately were going to turn out to be positive. So testing by day 5 only caught 3/4. In other words, missed 1/4 of the people ultimately who are going to be positive. Now, inside a household, there's continued exposure taking place, and that certainly is probably a factor inside of these data. But it does give you some sense that a single post-exposure test alone might not be adequate to find all patients. Let's talk a little bit about healthcare workers and what actually is the risk to a healthcare worker. So a very dramatic demonstration of the quantification of the risk comes from the story of the first patient found to be diagnosed with COVID in the United States who was not known to have traveled, who was not known to have had a COVID contact. The story over here was this was an individual who went to a community hospital in California with a very severe pneumonia. In this community hospital, they did not suspect COVID because the person had not traveled, had no COVID contacts, and they therefore managed this patient without any kinds of precautions. So nothing beyond hand hygiene alone. And 121 providers inside this community hospital had close contact with the patient without any precautions. Of those 121 people, 3 developed COVID, so a 2.5% attack rate, not inconsistent from the overall attack rate we saw in close contacts from the contact tracing studies before, right? Remember, they quantified at around 5%, but that was also including household-based transmission, which we know sort of brings up the average. So in this healthcare setting here, about a 2.5% attack rate for this very sick patient. The risk factors were aerosol generating procedures, and we spoke before about how those might contribute to infection by the nature of the interactions that they compel upon the healthcare worker with a very symptomatic patient, and prolonged contact, the important role of duration of contact. The bigger message, therefore, is that healthcare worker infections, by and large, tend to be mostly community-based. And what we see again and again is that the rate of infections in healthcare workers really parallel what's happening inside the community, and far more so than what's happening inside the hospital. So this is data from London, and shown in red over here is the population-wide incidence of COVID-19 in the city. You can see in blue over here is the incidence of COVID amongst patients. So the inpatient census of COVID in one health trust in the city of London. And you can see it lags, it's a couple of weeks beyond the peak that you see inside the general population. Then shown in the bars over here is the percentage of asymptomatic healthcare workers who turn out to be positive for SARS-CoV-2. And you can see it really rises in accordance with what's happening in the community, far more so than what's actually happening inside the hospital itself. And as community rates decrease, so too do the healthcare worker rates, even though the inpatient census remains high. So the message is that healthcare workers spend most of their time outside the hospital, and inside the hospital, of course, they're taking precautions, and that therefore their greatest risk for infection acquisition is outside the hospital. That's also borne out in seroprevalence studies. So this is looking at 13 different centers across the United States where they compared seroprevalence inside of healthcare workers compared to the general population in that same locality. And what you can see over here is that by and large, the rates mirror one another. In many cases, the rates amongst healthcare personnel is actually lower compared to what you see inside the outside community, with a few exceptions in which it goes in the opposite direction. So again, most healthcare workers are community acquired. This is a study here from Belgium that quantifies that factor. This was a hospital-wide seroprevalence study in Belgium, and they looked at the risk factors for COVID positivity, for COVID seroprevalence. And you can see over here, there was no signal associated with patient contact, with a COVID-19 patient contact, with a coworker contact, but a strong association over here with suspected COVID-19 in a household member. How does it vary by job type or where you work inside the department? So here's data from a hospital outside of New York City. The seroprevalence inside the community over here was around 17%. You can see amongst the healthcare workers, it was much less than that. And it was pretty similar, regardless of the kind of role that you played inside of the hospital. Likewise, in different departments, again, lower rates as you might imagine from the prior figure, amongst all areas within the hospital, and interestingly enough, the lowest rate of seropositivity inside the ICU. Again, perhaps reflecting the fact that once you reach the ICU, you probably know you have COVID and take sort of extreme measures to try to protect healthcare workers in those circumstances. So what then are the implications for the personal protective equipment that a person must wear? So these are the recommendations from the US CDC: an N95 or higher respirator, eye protection, gloves and gowns. Now, CDC does specify that a face mask can be an alternative. I would say, based upon the analysis that we've done together and the important potential role of aerosols in short-range transmission, as well as occasionally in long-range transmission, I would say that an N95 respirator is clearly preferred for healthcare worker protection, particularly if you're taking care of a symptomatic patient or a patient who's known to have COVID-19. How we flip this around, what's the risk to a patient coming into a hospital or getting care from a COVID-positive healthcare worker? So a couple of studies from our hospital where we took a look at this, we identified 226 patients who received care in our hospital and our outpatient centers, where it turned out that the healthcare provider who had seen that individual was subsequently diagnosed with COVID a day or two later. We followed each patient then out for 14 days to see if they developed symptoms, and we tested them. And amongst these 226 patients cared for by a COVID-positive healthcare worker, only one patient infection were we able to find. So the risk to a patient actually turns out to be quite low, and it's probably a function of the brevity of exposure between healthcare workers and patients, particularly in the outpatient setting. In terms of nosocomial transmission, if you get admitted to the hospital, also data from our hospital, between March 7th and May 30th, we looked after over more than 700 patients with COVID in our hospital and over 8,000 patients without COVID. And we reviewed every single patient who tested positive on hospital day 3 or greater to try to work out if it was likely community acquired and simply incubating on admission or initially missed on admission versus potentially hospital acquired. And we could only identify 2 cases we thought might have been hospital acquired. One was a patient in March who likely acquired COVID from a visiting wife who was diagnosed with COVID herself a day or two after she visited and before the patient himself was diagnosed with COVID. And one patient in April who did develop COVID after a long hospitalization. We could not identify the source of exposure, but we did feel like given the long hospitalization, probably was hospital acquired. So again, nosocomial transmission by and large tends to be rare. There can be exceptions. We did actually have a large cluster of COVID-19 within our hospital. The Brigham and Women's is my hospital. And let me tell you a little about that. Here's the picture of transmission that took place. The index patient was this individual over here. And the story was this was a person admitted to the hospital with symptoms of shortness of breath and tachypnea. She was tested twice by nasopharyngeal PCR, tested negative twice. And at that point, they made an alternative diagnosis of a COPD exacerbation and took the patient off precautions and continued to manage them. Unfortunately, this was an instance of a patient probably who was incubating on admission, was probably in that early period before symptoms, before the infection becomes manifest. And therefore, she was highly contagious, and it took us about a week there to make the diagnosis in this person. And during that period, she managed to infect a number of roommates, who in turn went to other floors and infected additional roommates, as well as a number of healthcare workers in multiple locations. All told, we had 14 patients who got infected, 38 staff members. The clonality was confirmed by whole genome sequencing. And again, the likely source was a patient admitted during the incubation period with negative admission testing. There was a high rate of transmission amongst patients who are sharing rooms, probably the in-hospital equivalent of being a household member. And some of the factors we think that may have facilitated transmission were that these were very early infections. So when people were at their at their highest level of contagiousness, right, immediately before symptom onset, immediately after symptom onset. This was a symptomatic patient. The patient was actually there was variable use of eye protection by providers. They were inconsistent, and they were inconsistent about masking of the patients themselves. And so those were some of our action items in trying to mitigate further infection inside of our hospital, is being better about all these different factors. So we mitigated this cluster by using preemptive precautions for all patients on cluster units and services. We undertook serial testing of all patients and staff associated with cluster infections every 3 days. We confirmed the adequacy of ventilation. We did aggressive messaging to our staff about the importance of eye protection and masking of patients. We made structural changes to break rooms and workrooms to decrease their density. And we now are retesting every patient who gets admitted 3 days after admission, just so we don't miss incubating on admission. And we now undertake serial testing of all patients who are getting aerosol generating procedures. Here's a very nice summary point over here of the protective measures against COVID-19. Comes from a very lovely study of Thailand, looking at close contacts of people with confirmed COVID and looking to see what were the factors that led to close contacts getting infected versus not. You can see over here the protective factors against transmission were distance, brevity of contact, washing your hands, wearing a mask, and wearing it all of the time. So bringing together in one study over here all the key prevention messages that can prevent transmission. Thank you very much.